that I'm going to be talking about an early childhood intervention program that we started working on in Ireland 17 years ago. And the aim of this project was to reduce social inequalities in children's skills and obviously as an aside, to help reduce child poverty as well. So I guess I don't need to tell this audience, but we know that inequalities in children's skills, arises very early in the life cycle. This can be either due to a family's inability to have the financial resources to invest in their children or due to the cognitive constraints that comes with living in long-term poverty. So as a result, a whole different range of early intervention programs, some of which we heard about today, have evolved to try to kind of counteract these risk factors that children experience and, with the optimal aim of trying to reduce inequalities. And one form of early intervention program is home visiting programs, as Silvana mentioned. Some of you may have heard of the Nurse Family Partnership Program, the David O's program in the US, but there have been other programs. Another famous one was originally called the Jamaica Study. It's now called Reach Up and Learn, and it's offered in many low-income and middle-income countries around the world. So we have evidence that home visiting programs are effective in the US, and we have evidence that they're effective in developing countries, but we actually have very little evidence that these types of programs are going to be effective in countries which provide a much more generous social welfare system to disadvantaged families, like in Ireland. So arguably in Ireland, we actually do, you may have seen Ireland. I'm not sure if any of you focused on Ireland in some of the presentations this morning, but in terms of child well-being, we're pretty good for a little country. We're halfway through that. I was looking at it, we're halfway through on that slope. We do quite well. We do provide a lot of financial support to disadvantaged families, but despite this, we still see very high inequalities in terms of children's skills. So we wanted to know whether this home visiting approach would work in an Irish setting. So the aim of this study then was to investigate the impact of a 5-year early intervention program, trying to improve children's developmental trajectories with the ultimate aim of reducing inequalities. And the name of the program, as Silvana said, is Preparing for Life. It is the longest running experimental early intervention program in Europe. And it's based on the premise that basically providing intensive support to parents from pregnancy until age 5, so very long, very intense intervention that will help to improve children's developmental trajectories. So as Silvana said, it was a randomized controlled trial, but it was a very small sample. So like Perry, it's a very small sample size. We were working in one highly disadvantaged community in North Dublin, and we recruited 233 pregnant women who we randomly assigned to a high and low treatment group. Both groups got some common services like developmental toys and book packs. But what Preparing for Life was about were these 3 intensive parenting supports that were only provided to the high treatment group. These included baby massage, very nice thing to do, parenting classes in groups, again, nice thing to do. But what Preparing for Life really is a home visiting program. So every family in the high treatment group had a mentor who visited the family's homes once every 2 weeks, starting during pregnancy and continuing until age 5. And the aim of these visits were really to support and educate the parents around parenting and appropriate child development based on a curriculum of about 200 different tip sheets. And that was the intervention. In terms of the trial design, eligibility was simple. You need to be pregnant and you need to be living in the catchment area, which, as I said, is one of the most disadvantaged communities in Ireland. We recruited at the maternity hospital, and women on average were about 20 weeks pregnant when they joined the program. And then we randomly assigned them to a high or low treatment group. Now, during the trial, we collected around 10 waves of data. So we did collect a lot of data from these families through interviews with the parents, through direct assessments of the child. We were also able to access their medical records and later their school records. And the intervention finished when they were 5 years old. So technically our study finished at age 5. But then we got more funding and we were able to go back to the children at age 9 initially. And at the moment we're in the field and the children are 14 years old. So what we're trying to do is track these children like Perry did to see whether these effects sustain or not. And all this data is publicly available data as well. Now, obviously, whenever you're talking about a longitudinal randomized control trial, attrition can be an issue, and attrition is an issue. So just to get that out of the way before we start. So at the end of the trial, we retained about 65% of the original sample. At the age 9 follow-up, we retained about 60% of the high treatment group and 40% of the low treatment group. And at age 14, who knows? We're still out there collecting every day and trying to get one more. So at the moment, I think we have 93 consents. So I don't know what the attrition rate will be. Now, I mean, this is a relatively high level of attrition. However, I would say one of the advantages, or the good news, I guess, is that attrition is pretty much random in PFL. People drop out, but there's no systematic attrition, or not much evidence that we have differential attrition processes in the high and low treatment group. But still, to address attrition, we do use inverse probability weighting to deal with differential attrition. To deal with the fact that we have a small sample size, we use permutation-based hypothesis testing, and to deal with the fact that we have multiple and many, many different outcomes, we use the step-down procedure by Romano and Wolf. So just to give you a context for all the results that I present to you today, they're all going to be intention to treat estimates using IPW adjusted permutation tests, controlling for gender, and adjusting for multiple hypothesis testing. Okay, so based on all the data that we've collected so far, we have produced 9 reports. It's got a lot of attention in the media. There's been lots of newspaper articles written about it. And we are now on to our second documentary about preparing for life. So there's a film crew who actually over the next couple of months are continuing to follow the PFL children, which is really exciting. And of course, we do write academic papers as well. So we have produced about 25 papers so far on the Preparing for Life trial, again, in multiple different disciplines, not just, well, I'm going to say not just economics, but the economics ones actually are relatively minor. We have published in econ journals, but also in kind of medical journals, education journals, psychology journals, wherever it seems fit. So I'm going to share some results for you, and not too many, because again, we haven't got too much time in this presentation, but just to give you kind of a highlight of what we found. And here I'm kind of focusing on outcomes that are, if you like, this is a session on child poverty, and looking at, some of the factors that predict poverty. One of the factors is cognitive skills. There is certainly association between lower cognitive skills and higher levels of poverty. So at age 5, at the end of the trial, we measured the children's cognitive skills using the British Ability Scales. That gives you an overall score, and then various subdomains. And then this is the mean and standard deviation of the high treatment group, mean and standard deviation of the low treatment group, the effect size, and the p-value. And what we can see is Preparing for Life in the high treatment group consistently have higher scores than the low treatment group. The results are both statistically significant, and I guess this is the important bit, they're clinically significant, with very, I would say, large effect sizes for an educational intervention. So we're seeing effect sizes of about 0.7 of a standard deviation, and this compares to an average effect size of about 0.2 once you look at the literature on educational interventions. So the program really has boosted the children's cognitive skills. If you just look at the mean difference in scores between the high and low treatment group, we're seeing almost a 10-point gap. So there's a 10-point gap basically between the high and low treatment group. And you could kind of consider this as a proxy for IQ. Okay. So basically a 10-point difference in IQ is what the program did during the program. But what you often find with these early intervention programs like Perry and Abecedarian is you see a fading out of those effects on IQ once the program ends. And basically the control group kind of catches up, right, once the treatment ends. So we wanted to assess this in PFL. So that's one of the reasons we went back at age 9. We wanted to see, well, what happens? Are the effects still there 5 years later or 4 years later? And in the meantime, the children haven't received any additional intervention. They've gone off to school. And what happened? And what we're finding is that there was no evidence of fade out within Preparing for Life. And I think this is one of the things that distinguishes it from some of the other intervention programs is we're not seeing that fade out in terms of children's cognitive skills. These large effects that we observed at age 5 or during the trial seems to be persistent. And there's various reasons we can talk about that may be the case. One being, again, this is an intervention that starts during pregnancy. So we saw that wonderful graphic or video that Silvana showed about brain development. And where basically this intervention is intervening at that most important period when those neural connections are being made. So perhaps one of the reasons we're seeing this persistent effect at age 9 and maybe at age 14, but who knows, is because it actually changed the children's brain development. Okay, so at age 9, we're seeing the same effects. The results are statistically significant, and the effect sizes are still large, right? We're still seeing effect size of 0.67 of a standard deviation. So it's fallen a little bit, but really the size of the effect is still is still very, very strong. Now, obviously, one of the focus on this workshop is child poverty. And obviously I can't look at, and we know that there is, as we saw this morning, we know there's an intergenerational transmission of poverty. We can't look at the intergenerational transmission of poverty within the PFL sample yet, as the kids are only 9. Child labor is bad apparently, so we can't go and measure their wages yet. But what we can look at is the intergenerational transmission of IQ, because we do have IQ scores from the mothers and we have IQ scores from the children. And we can look at, what has the program done? Has it broken the intergenerational transmission of low IQ? So a study by Black et al. Finds that the correlation in IQ scores between fathers and sons is about 0.38. Okay, and this is a large, obviously, registry data, big sample size. Generally, that's the correlation you find between parents and their children's IQ scores. So we first look at the low treatment group. So the low treatment group is like our control group. And we're looking at the correlation, the IQ scores of the mothers and then the children, the low treatment group. And it's basically what we would expect based on the regular IQ correlation there. The correlation at age 5 is 0.3, so very much in line with this national study. And at age 9, we're actually finding a much stronger correlation between the IQ scores of mothers and children of 0.57. Again, this is a very disadvantaged cohort. The IQ scores of the mothers is coming from relatively, they're very relatively low. Okay, so we're finding low IQ, kind of intergenerational transmission of low IQ in the low treatment group. But when we look at the high treatment group who've received this intensive parenting intervention from pregnancy onwards, we're finding that there's absolutely no evidence of a correlation between the IQ scores of the mothers and the children who received the intervention. So we can see that the correlation coefficient of 0.07 at age 5 and 0.18 at age 9, and no evidence of significant correlation. So there is some evidence that the program has, if you like, it's broken the intergenerational transmission of low IQ. So potentially this means we may actually, if the program continues to have an effect, we may see that there's it breaks the intergenerational transmission of poverty as well. But again, at the moment, that's only suggestive. In addition to age 9, cognitive skills are important, but there's lots of other more important skills that we have, and executive functioning is certainly one of those. So at age 9, we measured the children's inhibitory control, attention flexibility, and working memory. And consistent with the cognitive results, we're finding that the program did boost these skills too. The children in the high treatment group consistently had better executive functioning scores than those in the low treatment group. And again, with very sizable effect sizes of about 0.6 of a standard deviation, which is a very large effect within these types of home visiting programs, early intervention programs. So that's consistent. At age 9, then we also measured their math scores and their reading scores that they do in school. And again, we're finding consistent effects. Okay, the program, the kids who received the intervention had better math scores, had better reading scores. Again, effect sizes vary, but they're somewhere between 0.3 and 0.7 of a standard deviation. So we're seeing a very consistent effect in terms of cognitive, or what economists used to call hard skills, in terms of their cognitive skills, their executive functioning skills, and then achievement tests as well. So they're good skills, but there's also other skills that we have that we know are equally, or if not more important for certain domains, and that's our socio-emotional skills and our behavioral skills. So we measured just this during the trial using the child behavioral checklist. And here I'm reporting the results during the trial and at the end of the trial, so at 24 months, 36 months, and 48 months. And here I'm reporting the proportion of children who fall within the clinical range of externalizing problems and internalizing problems. And again, we're seeing pretty consistent results. The children who were exposed to the program, who took part in the program, are less likely to be within the clinical range in terms of both externalizing behavior and internalizing behavior. And again, with quite healthy effect sizes as well. So this was during the program, we're seeing these effects. I would say, however, that the impacts we see on children's socio-emotional skills and behavioral skills were always a little bit weaker and maybe not as robust as those effects we were seeing on cognitive skills. So I guess perhaps at age 9, it was not completely surprising that we actually found that the effects on these skills were no longer present at age 9. So at age 9, we assessed these skills using both maternal reports, which was the same that we used during the trial, but now the children were 9 years old, so we also could do direct assessments of the children, where we measured internalizing and externalizing problems and a few other things. And we find no evidence at all that the program has had a sustained impact on their socio-emotional skills or their behavioral skills at age 9. So again, no fade out in terms of cognitive skills. We are seeing this fade out in terms of their behavioral problems. Now, we have many, many other results from those 25 papers. Obviously, short presentation, I don't have time to present them all. I haven't included the health effects in this presentation, but in terms of health, we observed some effects during the program. So we saw that the program reduced the incidence of cesarean section, for example. So that was a very early win. They only started receiving the intervention at 20 weeks, but still it had some impact on their labor outcomes. During the trial, we also found that the program had some impacts on reducing hospitalizations as well. There were some effects in terms of improving their eating behavior. We also found there was effects on someone mentioned obesity and overweight this morning. And again, we found that there was reduction in the proportion of children who were overweight and obese as well, the high treatment group during the trial. But by age 9, all of those health effects were gone. They were no longer present. So the only consistent effects that we're finding is in terms of the, if you like, the hard skills. This is a session on the economics of poverty. So I told I should put in some numbers, some economics, the economic benefits of preparing for life. So in terms of how much this program costs, it is a very intensive program. It lasts for 5 years. We started recruiting during pregnancy. It lasts until the kids start school. So it is, I would say, a relatively expensive program. In terms of costs, it costs about $2,250 a year. This is US dollars, by the way. Sorry, I should have converted it into Canadian. So it's about $10,000 per child to take part in this program. It's basically equivalent to the cost of the nurse-family partnership. Okay, so it's actually not that different in cost to that. But how about cost savings? Well, as I said, we did find that the program reduced how frequently the children were going to hospital, and obviously there's a cost saving associated with that. So we estimate that the cost savings is about $1,500 from less likely to go to hospital. I said that the program reduced the proportion of children who had a cesarean section. The cost of having a cesarean section in Ireland is about $6,000. Also, there was this study done by O'Neill et al. Who calculated that the cost saving from moving a child from being above the clinical threshold to below the clinical threshold in terms of behavioral issues is about a once-off cost saving of $15,000 at age 30. So this was a kind of a cost effectiveness study that they did in Ireland. And then again, as I showed to you in this presentation, we found that the program did indeed reduce the proportion of children scoring within the clinical range from 17% to 2%. And then I think finally, in terms of IQ, we don't have any cost data in terms of projecting the likely cost savings from having higher IQ from Ireland, but then using data from Vergunst et al., they find that a 1 unit increase in IQ scores generates an annual increase in earnings of $1,500 by age 35. Or then if you extrapolate out that from 10 years of working, it's generating an additional $15,000 earnings over a 10-year period. So again, we haven't done a formal cost benefit analysis of preparing for life yet, but if you just take these figures into consideration in terms of cost savings that the program has already generated or likely to generate in the future based on the results we've already observed and the cost of $10,000, the program has already generated what we would call a positive return on investment. Okay, so preparing for life is likely to generate a positive return on investment. Once the formal cost benefit analysis is completed, I'll let you know. But again, it's Silvana showed a table of results or showed them a slide that looking at the economic returns to different programs. And again, preparing for life is likely to have a very healthy economic return as well. So just to summarize findings then, we found that the program had a sustained effect on cognitive skills and achievement tests at age 9, but we're not seeing any consistent effects on socio-emotional skills or the children's health outcomes. Potentially this could be because the child has more agency over their health once they get older from when they're very little in terms of the food they eat or how frequently they exercise. In terms of socio-emotional skills, I have various reasons for why, but not reasons. Potential explanations of why we're not seeing treatment effects there anymore. But again, it's speculative. We don't really know why the program, those effects on socio-emotional skills are no longer there. But in terms of why the effect size we observed on PFL seem to be much larger than other studies, it is potentially due to the fact that preparing for life, it's starting earlier and it's longer in duration than most other home visiting programs. Most other programs start either after the birth of the child or before the birth of the child, but they only last for 2 years, whereas preparing for life is much longer. So what this means is how home visiting programs work is really by building this relationship of trust between parents and the home visitors. And because in PFL, they had a much longer time to develop that relationship, it means that the parents may have been more amenable to implementing the changes that the mentors were suggesting. We also have multiple treatments. It's not just a home visiting program. And just one final, almost final thing, I should say, before I run out of time, is just before Christmas, we found out that preparing for life was added to the US's Department of Health and Human Services Home V list. unless you work in home visiting literature, you probably don't know the home V list, but it's actually a very important list. Basically, they review all of the evidence that's ever been published on a particular program, and they deem whether or not it's high quality or not. So, or whether or not it's an evidence-based early childhood program or not. And Preparing for Life, it took us years. We started this like 5 years ago, but finally Preparing for Life is on the home V list. And what this means is if any organization in the US wants to implement Preparing for Life, they can apply for federal funding to fund it, because the federal government will only fund programs that are on this elusive list. So PFL is one of the programs on that list. And just to finish off with 2 projects that we're currently working on. The first, as I said, we're currently in the field. We're looking at the impact of PFL at age 14. I had hoped, when I agreed to give this presentation, I had hoped I would have the age 14 results. I don't. We're still in the field trying to collect data, so we'll have those results late summer. And I guess one other interesting development is, one trial is great, one RCT is fab, but like, what about the generalizability? You ran one trial in one place at one point in time. Replication is key. So we have had the opportunity that we are now doing a replication trial. We're running Preparing for Life in Chicago. We're working with the Center for the Economics of Human Development at the University of Chicago. Our implementation partner is Casa Central. The name of the program is Creciendos Juntos. So we're working with a primarily Hispanic and Latino population. And this trial is just starting, and I'll be working on it for the next 20 years. So thank you.
Yes, we have time for 2 questions. And while you think about your question, I want to mention that you started PFL 20 years ago, right?
17 years
ago. So that's the time it takes to get results on a trial like this. Yes.
I've already asked a question, but I do a bit, if there's no questions, so thank you very much.
Oui.
Thank you, Orla. That was really, really exciting to hear about this and the results that you've got and so on. I wondered if you could just say a bit more about what the program consisted of and which are the bits that you think are making the difference. And also whether you collected anything on like positive parenting attitudes, sort of intermediate things which might help explain the results.
Yeah, we did. Obviously, in a short presentation, it's not possible to show everything. Normally, I would have many more slides on the curriculum itself and the program itself. So the program very much comes at the home visiting approach that's based on building the strengths of the parents and working collaboratively with the parents. So the home visits are about an hour and a half long. It's very much based on, there's a couple of tip sheets that the home visitors will bring to the home visit, but there's a lot of flexibility. When I look at other home visiting programs and talk to people who work in other home visiting programs, they're kind of shocked by how flexible PFL is, in that it's not, if the home visitor has the autonomy to say, you know what, this parent is fine, doesn't need to go through those tip sheets. They've got that down. What they really need is to work on these things. So it works with the family where they're at. It builds the strengths. They use role modeling, they use demonstration, coaching to deliver the intervention. But I think the biggest difference from PFL, when I look at it, say, to Early Head Start, is the flexibility. Talking to home visitors who work on other programs, they have to go in and do this today. They have to have a visit X number of times. They have to make sure that they meet all these milestones. PFL is very flexible. Now, that can be a good or bad thing, but because they have the flexibility to meet the family where they're at, they won't insist on meeting the family every 2 weeks if that doesn't suit the family, There's a lot of flexibility. So it's very holistic building. The key ingredient of the reason, we did a lot of qualitative work, didn't show it today. We did a lot of qualitative work, and it's the relationship. It's the better the relationship between the mentor and the parent, the better the outcome, right? What we find is if someone had to change mentor because the mentor got pregnant herself or moved or something, that we saw was a big determinant of bad outcomes. Okay, so maintaining that relationship was the most important thing. In terms of intermediate outcomes, we collected everything around parents, parenting beliefs, self-esteem, self-efficacy, quality to home learning environment, maternal mental health, maternal employment, you name it, we collected it. I come from an economics background. I'm used to longitudinal cohort studies that have like hundreds of, so we basically did the same thing. We had all the data you could imagine. We had more data than participants, which is a problem in terms of doing our analysis. We did find effects on parenting. There were changes in parenting, but actually not very strong effects on parents. For example, the program had no impact at all on the parents' mental health, which we were surprised about, but it didn't. But again, it wasn't designed to improve parents' mental health. It was designed to improve children's skills, and it did. The biggest areas where we found effects in terms of parenting was the quality of the home learning environment. They improved the quality of the home learning environment. They were reading more to their children, talking more to their children, stimulating their kids more. They changed their behavior around the kids, but they didn't change their internal beliefs or mental health or those types of things, you know. Yeah. Thank you for your question.
Oui, je vais prendre quelqu'un qui n'a pas posé de question encore, si vous permettez.
Thank you. It's Josie Dickerson from Bradford in the UK.
Hi.
I think thinking about this, it is quite a resource-intensive program.
Yeah.
And I was just wondering about your thoughts around scalability, because we've heard a lot today about how people are finding it hard to deliver services and poverty is increasing. So have you got any sort of ideas about how you could achieve that?
Well, in terms of, yes, it's a very valid question and something we think about a lot. I would say that the program is now being rolled out in 9 other communities in Ireland and in Chicago, which is our 5th or 10th community, as we like to say. So it is being, like, this is a highly targeted intervention. It was never designed to be universal. It was never designed that every mom would have a mentor from pregnancy onwards. These are the most, because it's an expensive intervention, a very long intervention, it should only ever be targeted at the most disadvantaged families. It's because ultimately, from an economic perspective, they're the ones that cost the state the most money, so we're going to invest in them early on. So it's scalable if you keep it to focusing on at-risk families. And as I said, it's currently being rolled out in 9 different places around Ireland and communities, and it's working well. Could it be made larger? That's the issue. There are implementation issues. Even there's implementation issues at the moment in terms of maintaining fidelity. How scalable is it? We see this as a demonstration project. You invest a lot. It works really well. So, but yeah, it's an issue. We're hoping to maybe do something with that in the Chicago trial to see if we can address that.
One last question.
Thank you. I'm really impressed by the consistent results, the positive results of the intervention over years. But then at age 9, assume you cannot show it anymore, the difference between intervention and control group. Is it that we cannot measure it, or does it just fade out? And if so, what would it mean for economic projection, for example?
Well, we are seeing consistent effects in terms of cognitive skills, achievement tests. They're all consistent. So those effects are still there. And those effects are so large that it will still make the economic return positive. Yet where you're right, though, where we aren't seeing those consistent effects is in terms of socio-emotional skills and health outcomes. Will that negate the economic impact? I don't think so, because when you look at the peri-preschool program, who found and the Abecedarian program and even the Jamaica program, who all did see fade out after the intervention, but then once they followed those children up into adulthood, they're still seeing less crime, better employment, less social welfare dependency. Almost it could be there's some latency effects that I think you're right could be down to measurement, and measuring socio-emotional skills perhaps isn't as easy to do as something like cognitive skills or math skills or reading skills. It's, because it's based on self-report, basically, it's very hard to get a very objective measure. It could be measurement issues, or else it's a latency sleeper effect. But despite that, improving skills at that age is still important in and of itself, I think, even if you're not seeing at age 9, because I think it will have an impact in the future. Thank you.